Good evening to all. Many times, the systemic diseases leaves its marks on the skin, and a sharp clinician can pick up this clue and diagnose the disease. To speak about these cutaneous manifestations, we have a dermatologist here. It's my pleasure to introduce Dr. Bifi Joy, Professor, Department of Dermatology, Govt.Medical College, Kannur, Pariyaram. He did his MBBS from Govt.Medical College, Kottayam, and MD in Dermatology from Govt.Medical College, Trivandrum. He is an undergraduate and postgraduate teacher since the last 15 years in Pariyaram Medical College, and he is a member of the Central Scientific Committee of Indian Association of Dermatology, Kerala chapter. He was the scientific secretary of the first ever PG Con South in 2017, and he is a regular speaker in regional and national academic forums. His areas of interest are clinical dermatology, venereology, and pediatric dermatology. I welcome Dr. Bifi for the speech.
Good evening. Thank you for those nice words of introduction. Hope I'm audible. Fine. Okay. Let me at the outset thank the members of IMA Kannur, especially the Secretary, Dr. Rajmohan, and Dr. Manu for having me here and for inviting me. It's actually thanks should be due to two reasons. One, it has given me an opportunity to present in a very erudite crowd where very learned senior doctors are there. And secondly, it has also given me a chance to catch up with my friends, Dr. Vimal, Dr. Sharif, and all. So it's so in two ways, it's quite satisfying moment for me to be here. Without further ado, let me just go into the topic proper. When Dr. Manu approached me to choose a topic for today's session, I was just thinking, and in discussion with him, I thought I will take a topic which should be of interest and which should cater to the interest of most of the specialties to which the doctors here belong. So I just thought I will take this topic of cutaneous markers of skin disease. Eyes are the windows to the soul. The skin is the window to within. This is a very apt statement because most of the time what we see on the skin is a reflection of what is happening inside. So it actually gives you a view of what the internal system is going through. If there are any side effects or if there are any systemic effects which are happening inside, that is reflected on the skin in various fashions. Let it be a general change, like probably the skin will be a little dry and all. It will suggest some sort of a dehydration or a generalized debility. Or it might be a pointer to an underlying systemic disease. Today, I'll be focusing more on somewhat common and specific cutaneous signs in systemic disease. I have no conflicts of interest. Today, when I'm presenting the topic, my idea is to just sensitize you to the cutaneous signs in systemic disease. So I won't be going into any detailed into the etiopathogenesis or any of the other aspects. It will be just showing you certain cutaneous signs and features with which, when you look at it, you need to suspect systemic involvement and probably evaluate in that direction. The objectives of my talk will be to revise and sensitize this audience regarding skin signs in systemic disease. Now, when I say revise, it is basically because whatever I say, many of them you would have already know, and many of them you would have already come across in the different deliberations, different conferences, and maybe even you might have read it in the literature. So it will be just revising you and sensitizing you to that, so that you need to pick those lesions when you see that, and then you can use it to evaluate the underlying systemic afflictions. Secondly, my idea will be that after this talk should prompt you to suspect and to evaluate and investigate and even refer patient to appropriate specialty when you see relevant systemic features. So my basic way of going around this will be not in a theoretical fashion. I won't be filling my slides with any technical or any theoretical jargon. My slides will have images and then the pointers or the systemic ailments to which they actually point to. I think that would be the one thing which will interest you most, rather than going into too much of theory. So as a disclaimer, let me say that I won't be going into any detail into the treatment or the theory part of those conditions. It will be just that you see a lesion and what systemic ailment you need to suspect. And being a part of a specialty, which is a very visual one, where everything is visible on the skin, my basic tool in all these will be images. And with this, I will try to convey how skin and the systems are interconnected. And I will be, there are innumerable number of cutaneous signs and features, but it is beyond the scope of today's discussion to discuss each and everything or to even mention. So I will be just highlighting very common and certain specific type of cutaneous signs and features. And I'll be using I'll be doing it in an alphabetical order from A to B, C, like that till the final letter of the alphabet I'll be using. And at the end, I will probably put two picture quizzes too, so that you can actually tell us what the diagnosis is. Very common things, but still, I think just to keep you interested. And it will be a quizzical form of fashion, where each slide I first project an image, just give you a description, and I will ask you to probably think aloud. You can actually prompt the answers, or you can think it in your mind, and then we'll discuss the same. So coming to the first alphabet A, this is something which we commonly see. Patients usually present to us with velvety hyperpigmented plaques on the nape of neck. This is the one which I think most of you would know. Starting with A, this is the acanthosis nigricans. Now, this is commonly seen in obesity, and but at the same time, this is a pointer to certain systemic ailments. The most classical thing is that this will actually be a pointer to insulin resistance, and diabetes is the commonest accompanying associated systemic illness. But at the same time, to a gynecologist, this will be an area of interest, because this will be a pointer to a polycystic ovarian syndrome. Also, it can be part of autoimmune diseases like SLE, and other endocrine disorders like hyperthyroidism can also present with acanthosis nigricans. All these would probably come under the benign types of acanthosis nigricans, but the serious part of it is that at times this could be a pointer to malignancies also. And how you differentiate it from a benign acanthosis nigricans is that malignant acanthosis nigricans will be extensive, and if you have similar involvement of the palms and soles and the mucosae, then that is a pointer to malignant acanthosis nigricans, and the most common underlying malignancy is gastrointestinal tract malignancy. So you need to evaluate for that if you have an involvement of the palms and soles and the mucosae. Next, this is something which you commonly see. These are skin colored, hanging sort of lesions on the commonly seen in the neck and the axilla, which we commonly call as skin tag. But scientifically, the term would be acrocordon. And this is usually benign. But if you have multiple acrocordons at different sites at the same time, it is a pointer to underlying diabetes. And you need to evaluate for diabetes if it has not already been done. And this is called as Templeton's tags or Templeton's sign. And this acrocordon is not always benign. This could be a marker of the metabolic syndrome. Now, this is regarding pigmentation. Now, many systemic conditions can present with pigmentation in various forms. They can be localized, they can be diffuse. But when you have pigmentation with this diffuse, and when the pigmentation, when you look at it, if the pigmentation is accentuated over the creases and the knuckles, then that is a pointer to the Addisonian type of pigmentation. Now, the Addisonian type of pigmentation occurs with adrenal disorders and any disorder which affects the adrenal gland. But at the same time, this can be a pointer to certain other ailments also. For example, this is a marker or this is a presenting feature of one of the vitamin deficiencies which can present with anemia as well as which can present with neurological disturbance. Any idea what that could be? Yes, it's a vitamin B12 deficiency. And as I said earlier, any condition which affects the adrenals can also lead to an Addisonian type of pigmentation. So when you have an Addisonian pigmentation, not always is it directly adrenal only. It could be due to other conditions also. Now this is coming to the second alphabet, just as a clue for you. When we deal or when we tell you regarding skin changes, you should also know that appendages or the skin appendages also can have its own changes, which are a marker for the underlying systemic disease. And the appendages are the hairs and the nails. So this is a nail change, which is a marker of underlying stress, whether it is a physical or a psychological stress. It occurs as you see in the picture, there will be transverse furrows or almost depressions on the nail. And it can occur at different levels. And this is what is called as the Boss lines. And this is a marker of chronic renal failure. This could be a marker of long-standing diabetes, and this could be a marker of different systemic failures. Like even it can occur in congestive cardiac failure. It can occur in chronic liver disease too. Now, one thing which is interesting is which is something which is a pointer is that when you look at this line, the site of the line actually will give you a clue to the time when the stress occurred. That is because the nail usually grows at a rate of 0.1 mm per day. And if you know where this particular line is, then you can predict how many days prior or maybe how many weeks prior that particular stress occurred. So that is a medical legal importance, and that is one of the practical importance of seeing this particular line. Now, this is something which a dermatologist often gets an opportunity to diagnose this particular medical condition first. Many times to us, the males present to us with multiple itchy pustules and probably scattered pustules called satellite pustules with maceration over the glans penis and inflammation of the foreskin. Similarly, females can present to the gynecologist or a dermatologist with curdy white discharge and severe itching over the vulvovaginal area. This is the classical candidal villanopostitis or vulvovaginitis, and many times this is the first presenting feature of underlying diabetes. This is another color change which occurs. Again, the clue is the first alphabet will be C. So this is a yellowish discoloration which is seen on the palms and soles and sometimes even in the eyes. And this usually occurs due to a deposition of a particular pigment. Any idea of what this could be? This is a carotenoderma, which is a common accompaniment of hypothyroidism, and it can also occur in hypervitaminosis A. At times, you can also get red color due to excessive carotene, which is otherwise called as red carotenoderma, or at times it's also called lycopenia. Sometimes a particular excessive intake of a particular vegetable can cause the same. Tomatoes, which are rich in lycopene. People who take plenty of lycopene are supposed to have lycopenia. This is something which is seen in certain parts of Spain and Italy, where tomatoes is a very staple. Like they use tomatoes in everything. Now, this is something which starts with C, a little more serious. So far, we are discussing very probably a relatively benign conditions. This is where patients present with ulcers of the limb and there will be necrosis, which is seen by the black chard or the eschars which are seeing them. And one thing which will differentiate here is that it is not just your inspection, but when you palpate at the border, you will get a gritty feel, as if some sort of rock or rock dust is being deposited, which is a clue to the diagnosis. Any idea what this could be? This is a pointer of severe chronic kidney disease. And the one investigation that you will do is that you will do a calcium phosphorus product, and you will find out whether that is elevated or not. This is the calcific uremic arteriolopathy, otherwise called as calciphylaxis. So this is something which is a serious pointer. The classical catch here is that it won't be just a necrotic ulcer, but the margins will have some amount of concretions or rock-like deposits. So this is something which is common. This is the clubbing, and you can have various grades of clubbing, and you know the systemic involvement in it. Just to bring it into the fact that we should not only concentrate on rare or relatively rare, but common things also. I'm not going to detail regarding clubbing. I think all of you know what and which all systems you need to evaluate when a patient presents to you with severe forms of clubbing. Now, this is something which is commonly seen by dermatologists and also by surgeons and maybe orthopedicians too, because the patient presents with bony hard swelling on the skin, which can occur either localized or diffuse, which can be very superficial or which can be a large deep-seated one. And most of the times it is juxta-articular. And this hard lesions at times ulcerate and will extrude whitish material. Any idea what this could be? Good. It's a calcinosis cutis. So this is the calcinosis cutis which is there. And calcinosis cutis, as you all know, can be of two types. The metastatic type, where there is hypercalcemia, that is, there is increased calcium levels, and that will deposit. That can occur in conditions like sarcoidosis, milk alkali syndrome, hypercalcemia, so various features. Dystrophic is the one which is more common, where there is a tissue damage, and this can be seen in a variety of conditions. Now, one area where you need to think is that when you see such hard deposits which are deep-seated, extending into the facial plane, then you need to always suspect that there is an underlying muscular issue, and most of the patients will have accompanying proximal myopathy. That is the calcinosis universalis, which you see associated with polymyositis or dermatomyositis. So you can have circumscribed calcinosis, which is seen in most of the condition, but you have a universal type of deep-seated calcinosis, which occurs in dermatomyositis. This is a condition which is supposed to be a specific change in diabetes. Not very common to see in our population, but if you are a fair-skinned individual, after in long-standing diabetes, this is one of the markers for diabetes. The patient usually will give history of small papular red lesions on the legs, which later coalesce to form plaques or maybe even discrete to coalescent hyperpigmented lesions on the extensor aspect of the legs. This is the ones which we call as diabetic shin spots or diabetic dermopathy. And once you see it, you need to evaluate the patient for underlying diabetes. This is otherwise called the Binkley's spots. Now, this is another entity. Here, the patient presents with an erythema, a diffuse erythema, at times almost purpuric, and on top of that, that area will ulcerate, get necrosed, and the crust there will be bound down and get laid down. And when you get such bound down crust on the skin, we call it as ecthyma. And this is an entity which, even though it looks very innocuous, this could be a pointer to an underlying septicemia, especially pseudomonal. This is a condition which is called as ecthyma gangrenosum. And this can occur in severe immunocompromised states, plus this can occur in chronic liver failure as well as chronic renal failure. This is an entity which is relatively uncommon now, which was there for a long time after the institution of proper antibiotic treatment. This is relatively uncommon. This is where you get erythematous, annular, and arciform lesion on the legs. And this commonly occurs in children, and its association is with inflammation of the different layers of the heart, or its association is with carditis. So this is seen in acute rheumatic fever. This is the classical. Any takers? It is the erythema marginatum. Erythema marginatum, which we can, which is seen as an accompaniment of acute rheumatic fever, and it is said to have a direct association with carditis. It can precede, it can be associated with, and it is considered as a marker of carditis. This is something which is rare, but if you see it, you need to evaluate for underlying malignancy. This is where the patient will have multiple erythematous concentric rings, which resembles the wood grain. That is, once you cut the tree, then you see multiple rows of lines inside it, and this is the wood grain appearance. This is an entity called erythema gyratum repens, and it is associated with malignancies, many, but most commonly lung malignancy as well as your hematological malignancy. This is rare, but not so rare because previously when we used to look into literature, everything was only in outside India, but there are many cases now which are reported of erythema gyratum repens from South India itself. So it might not be that rare. You might come across these cases and then you need to suspect the same. This is something which again most of you might be seeing in your clinics whenever a patient presents to you with painful crops of red nodules on the shins on bilateral legs, and when you miss out the diagnosis in the first sitting, the patient might come back to you with telling that this red color has changed into slightly brown and has now become slightly blue over a period of 5 to 7 days. And this is what we any takers for this particular entity. This is the erythema nodosum. Now, most commonly erythema nodosum occurs in secondary to infections, and it occurs secondary to drugs. But at the same time, when we do not have an implicating infection or drug, it could be a marker for underlying systemic involvement too. It could occur in the following conditions. It can occur as part of inflammatory bowel disease, both Crohn's and ulcerative colitis. It can accompany systemic lupus erythematosus. It can be a part of rheumatoid arthritis. It can be seen as part of GI disorders, especially chronic gastritis is said to be associated with erythema nodosum and also malignancies. So erythema nodosum is not always benign, not always secondary to infection or drugs. It can occur due to these conditions too. This is another entity which is very commonly seen both by in the pediatrics as well as adult age group, where the person will present to you with lesions on the acral part, that is on the distal, maybe on the dorsa of the fingers or on the dorsa of the hands, and the lesion will be as seen here. You can probably see a central purpura or a raised vesicle and a surrounding ring of edema and erythema. This is the classical target lesion or the iris lesion. And once you see this, this is the erythema multiforme. And erythema multiforme, again, the causes are predominantly drugs or infection. And at the same time, if you do not have these implicating features, just like your erythema nodosum, it can also accompany systemic multisystem disorders like lupus, sarcoidosis, and polyarthritis nodosa. Now, one thing is that if you have a patient who presents to you with erythema multiforme, and you see lupus in that, the one good thing is that the systemic affection will be less. It is relatively common in DLE, and it is called as Rowell syndrome. Now, this is another entity which is very commonly misdiagnosed as tinea. A patient presents with lesions on the abdomen or the thighs or on the back, and you will see multiple lesions with central clearing, and you can see scaling at the margins. But what you need to be very careful about is that you use a hand lens or observe the lesion very carefully. If you are seeing the scale at the exact edge of the lesion, then that is the classical peripheral activity of tinea. But here you can see in the second picture, the scale is actually a little behind the erythematous rim. This is the trailing scale. This is an entity called erythema annulare centrifugum, which is usually benign secondary to fungal infections and all, but which can also be a harbinger of underlying systemic disease. Broadly, different types of erythemas called as figure 8 erythemas, and one of the classical ones is the one which I said, erythema annulare centrifugum, and it is also a marker, or it also accompanies hyperthyroidism, autoimmune hepatitis, inflammatory bowel disease, SLE, and even malignancies. So, erythema annulare centrifugum, or if you see a trailing scale, it need not be a very benign condition. So you can miss out, or you can misdiagnose and mistreat as a tinea, but you might be missing a more serious underlying condition. This is something which is there. The association is now considered controversial, but this is one of the things which is there in the literature, and still they say that there is a connect. Can anyone tell what this is? You see a line, you see a fissure which extends from the tragus to the other end of the ear. This is the diagonal earlobe crease, and this is otherwise called as Frank sign. And once you see a diagonal earlobe crease like this is a marker of, can anyone tell which system would be affected with this? It's a no, it's actually a marker of underlying ischemic heart disease. So this is a Frank sign, and this is a marker, and some people have even categorized or subdivided it into different grades of diagonal earlobe crease. If it extends to the other end, the chance of having an associated cardiac involvement might be around 70% and less or so. But now new literature has come which has actually refuted the entire association thing. But however, if you see a diagonal earlobe crease, it is worthwhile to evaluate for an underlying cardiac involvement if it has not already been done. This is something which is again, you see shiny, erythematous, almost oily type of lesions on the what do you call it, the extensor aspect of the leg, and this is the classical pretibial mixed edema, and this can be extensive or this can be localized. Can anyone tell, if you get pretibial mixed edema, what is it a marker of? So one thing is that mixed edema is a marker of hypothyroidism, but pretibial mixed edema is a marker of hyperthyroidism. It's a marker of Graves' disease. So that is why the G of the alphabet. Now this is another nail change which is there, and you can see that you have a peculiar type of nail. You are not seeing the lunula, the semicircular lunula. Instead, you are seeing two zones. One is a proximal white, and the distal here looks hyperpigmented. It is more of a red zone, and usually it can extend from being 20% the distal one or up to 60%. So it's supposed to be 50-50. This is the classical half and half nail, which is a marker of chronic kidney disease. At the same time, you have another nail. If the entire nail is white, that is a Terry's nails, which is also a marker of chronic kidney disease, but it can also occur in chronic liver disease and all. So half and half nail is a marker of chronic kidney disease, while Terry's nail can occur in both chronic kidney and chronic liver disease. So nails also give you a clue to an underlying systemic involvement. This is another entity where a person presents with erythema and edema over the periorbital area extending into the malar area. And this patient, if we know what to suspect, then we will always ask for a history of overt or subtle proximal myopathy, whether the patient has got any difficulty in raising the upper limb above the shoulders or combing, or difficulty in getting up from the squatting position, because the commonest accompaniment would be polymyositis or so this is a dermatomyositis. This is the telltale sign of dermatomyositis, which is called as the heliotrope rash. And this is because the terminology is said so, because after the heliotrope flower, which is supposed to have a peculiar look, which resembles the entire heliotrope rash. So it can be part of proximal myopathy. So one thing you need to remember is that it need not be confined to dermatomyositis or polymyositis only. It can also be a marker of systemic lupus erythematosus. This is something very common. All of you would have seen, very commonly seen in children, very commonly seen running in families. This is the ichthyosis. But ichthyosis is not always benign. In children, it can be accompanied by various syndromes. But in adults, if there is a rapid recent onset of ichthyosis, those patients should be worked up for underlying chronic kidney disease or chronic liver disease. It could be an accompaniment of these two entities. So a recent acquired ichthyosis is a marker of chronic kidney or liver disease. So that is one thing which you need to remember. Something which is very innocuous, something which appears very normal, something which you think as normal. If the history is that it is of a recent onset, then you need to work up for both chronic kidney and chronic renal disease. Now, this is something which I don't know. I've just seen one case, but I think many of the physicians might have seen. So this is two skin lesions of the same condition. The first picture actually shows erythematous, flat macules on the palms, and one area is slightly raised with slightly bluish in color. And historically, this will be painless. While the second one shows a nodule, a painful nodule on the digit. Can anyone tell what these two are and what are these the marker of? Very good. The first one is Janeway lesion and the second one is the Osler's modes. And these two are a marker of infective endocarditis. Now, this is something which most of the physicians or people who are dealing with chronic diabetes would have come across. Patient presenting to you with such hyperpigmented, hyperkeratotic papules on the lower limbs usually, sometimes on the upper limb also, and you will see the lesions, and this could be part of long-standing diabetes itself. But what is important is that when you see such a case, it is very important for you to ask the history of whether the patient has noticed any extrusion of whitish material from the base of the lesion, from inside the lesion during the course of the disease. If it is so, then it is a perforating disorder and it is a marker of underlying chronic kidney disease. And this disease is called as Kyril's disease. So the history, what is important here is if the patient has noticed an extrusion of whitish material from within the lesion. If that is there, then that is a perforating disorder. Otherwise, you can have simple chronic itching and chronic prurigo lesions in diabetes 2. So the history is extremely important in such an entity. Now, this is the spoon-shaped nails or the koilonychia, which often accompanies iron deficiency anemia. But what else do you look for systemically in such a case? It could be a part of your Plummer-Wilson or Patterson-Kelly syndrome, where the patient will have, I think the radiologist will be probably able to tell us better. The esophageal web, which can be probably detected by usually by investigation. Such patient can give you sideropenic dysphagia. Patients will give you a complaint of dysphagia too. Now, this is the hair change which is there. If you are able to make out, you can see two parallel bands of hypopigmentation, while a slightly normal pigmentation above. This is, I'm not going to tell you the common name first. It is called as the Morse code hair. The common name, the alphabet is F, and it is a marker of protein energy malnutrition. And I think Dr. Zulfikar knows. This is the flag sign of previously considered to be telltale sign of kwashiorkor, but now they tell it is more in the marasmus and broadly under protein energy malnutrition. This is just the periorbital edema and the pudgy thing. This is mixed edema in hypothyroidism. Now this is something you see the patient presents with. Now the issue with us is that most of the time patients presents to us with these sort of erythematous lesion. But what you can see is that this erythema has occurred on the seborrheic area. So how do you know that this is not seborrheic dermatitis, and how is it that this is a malar rash? So that is one thing which you need to have a very careful observation, because the seborrhea occurs at the same site, and maybe the patient has supplied something and the scaling has gone off and it looks just red. So what you need to look for is the specific site. The specific site to look for is the nasolabial fold. If the nasolabial fold is involved, that is seborrhea. If it is uninvolved and spared, that will be a malar rash. And the malar rash is a marker of, as you all know, it is a marker of SLE, and the associated systemic involvements of SLE could be there in the patient. So what is important for us is that most of the time this seborrheic dermatitis also looks like the classic malar rash. So you have to look at the nasolabial area and see if it is involved or not. Now this is something which is, again, this is a definitive specific sign in diabetes, where a patient presents to you with well-defined erythematous to shiny, slightly oily plaques on the extensor aspect of the lower legs. Any idea what this entity is? Starts with N. This is the necrobiasis lipoidica diabeticora. This is an entity which is there, which is specific for this. I can see smiles and in the audience. See, basically dermatology is a specialty which has got a lot of images and at the same time lots of terminologies also. So if you have a penchant for terminology, I think dermatology is a wonderful specialty to be part of. If not, it is. But at the same time, you need to understand that most of the terminologies are self-explanatory. You have necrobiosis lipoidica diabeticora. So there is necrosis, there is biosis, there is a lipoidal distribution, and it is secondary to diabetes. So this is, if you know that, then it is very easy for you to at least know what this could be and it is associated with what. This sort of a smile we usually encounter. Most of us dermatologists encounter when we present in a common audience, when we use all these sort of terminologies. These are the terminologies which are there. Secondly, another thing is that this is something which I think nephrologists and physicians will be commonly seen, where patients with chronic kidney disease present to them. This has got this is not a quiz as such, but this is not something for you to see, just to point out a relatively rare entity, but something which is very commonly done, especially when people undergo contrast imaging in chronic kidney disease and gadolinium contrast image. And such a case, they often present with fibrosis and bound down skin over the extremities. This is called as nephrogenic systemic fibrosis. Again, a long term, but again, nephrogenic, secondary to kidney disease. It has got fibrotic, this on both the skin and the internal medium. This is a condition which at times can be mistaken for tinea. This is not common, at the same time not rare though. Around 4 or 5 cases have already been reported from Calicut, and this is a condition where the patient presents with reddish spreading sort of very livid erythema, which then starts to become necrosed at the margin, and the patient starts to get ulceration there, usually associated with significant diabetes and weight loss. In such an entity, can anyone guess what this could be? This entity is called necrolytic migratory erythema, and when you investigate, that patient will have a alpha cell tumor of the pancreas, or it is an accompaniment of glucagonoma syndrome, and it responds excellently to octreotide. The moment you give, within a week or so, the entire lesion actually disappears. So this is a necrolytic migratory erythema, which is an accompaniment of glucagonoma syndrome. Rare, but I think it's worthwhile for you to know when you see a condition like this, you can always try to suspect that. Now, this is a case when a patient will present with, excuse me, somebody said Peutz-Jeghers syndrome. Okay, Peutz-Jeghers syndrome. Probably the picture is not that clear. What I have shown here is purpuric spots on the lips, and you can have purpuric spot on the lips as well as on the tongue. Peutz-Jeghers is where you will have hyperpigmented small macules, and you can have circumoral pigmentation. And when you have this circumoral pigmentation, you have to look for underlying colonic changes. But when you have purpuric lesions on the lips and on the tongue, you need to ask for family history of the same, and you need to ask if the patient has got similar lesions anywhere else in the mucosa. If that is so, then that could be a pointer to hereditary hemorrhagic telangiectasia. Now, this is something which is there, which has been seen in plenty in South India, and in Kerala itself, around 10 to 20 cases have already been reported. It is supposed to be underdiagnosed because this usually remains innocuous. But what is important to know is that this can harbor some other changes inside. The commonest systemic accompaniment is AV malformation, especially in the lungs and the hepatorenal system. So just small purpuric lesions on the lips and the tongue is not simply innocuous. It could be harboring something more sinister inside. This is the palmar erythema, and this can accompany chronic liver disease, thyrotoxicosis, rheumatoid arthritis, and whatnot. So many entities which are associated with the palmar erythema. This is an entity which I think most of you would have come across, where the patient presents with multiple reddish lesions on the extensor aspect of the legs. Now, this could be a purpura, this could be a erythema. For that, we simply use a glass slide to differentiate between the two. You just apply pressure with a glass slide on the lesion, and if it blanches, it is a erythema. If it doesn't blanch, it is a purpura. And once you make a diagnosis of purpura, if it is a flat purpura, that will be secondary to platelet causes or thrombocytopenia. But if it is a raised purpura or a palpable purpura, then it will be due to vascular causes, and it will usually be an accompaniment of various types of vasculitis, which can be skin-specific or cutaneous vasculitis only, or which can be systemic vasculitis. So, and when you look at the systems, the most common association is with the renal system, or the kidneys are the ones which are most affected when you have palpable purpura and underlying vasculitis. And second is the GI. Now, this is another entity, something which has been seen, and we've actually got references from our own part. Multiple number of cases are seen, and this responds also excellently to therapy once we make a diagnosis. Yes. Which one? No, probably resembles a little like that. The first one is that the patient presents to you with a large necrotic ulcer, but what is important is that you look at the margin. The margin will actually show a small erythematous to violaceous, or what is written in literature as the lilac border. And this is a particular entity, and when it heals with a slightly netted pattern, or the cribriform pattern. And this is the classical pyoderma gangrenosum. Can anybody tell me what is the causative organism of pyoderma gangrenosum? Anyone? Okay, it is good that nobody guessed, because it is a misnomer. It is not a pyoderma. It is just a vasculitis, and it is not secondary to any. It's just a misnomer because of its look. And the accompaniment is usually the inflammatory bowel disorder, both ulcerative colitis and Crohn's. It can be also a part of rheumatoid arthritis, monoclonal gammopathies, malignancies, chronic active hepatitis, and multiple systems. So when you have an ulcer like this, it can be a pointer to an underlying serious systemic ailment. This is another entity, rare, but if it is there, it could be a pointer to underlying immunocompromised, and sometimes hematological disorders too. This is where the one lesion which we saw earlier, the purpura, can become diffuse and become ecchymotic, and the skin starts to char and necrose. Any idea what this entity is called as? This is the purpura fulminans. It usually accompanies, as I said, hematological disorders and also septicemia. And meningococcemia or gonococcemia is said to be one of the things. And at times, what you need to look for is that this could be a pointer that the patient might sooner or later develop circulatory shock and adrenal shock, the classical Waterhouse-Friderichsen syndrome, which can occur. This is another nail change. What is seen here is the lunula is completely red, or the semicircular area is complete. Now that suggests a vascular change, and it could be a marker for systemic lupus erythematosus, your peripheral occlusive vascular disease, and sometimes even it's a accompaniment of sarcoidosis. This is another entity. For us, there are lots of causes. When we see multiple such pits on the nails, this could be a marker of psoriasis. But at times you can get isolated pitting or isolated depressions on the nail of the index and the middle finger. When you get that, any idea what that could be a marker of? It is a marker of underlying diabetes. And that entity is called as Rosenow's depression or Rosenow's pitting. This is an entity which is not connected with any system as such, but it is more connected with the psyche. That is, this is something with which the patient will present you with hyperkeratotic papules or coalesced plaque on the knuckles. And if you are a very good historian, if you ask the history, you will get history of, yes, very good. It's a marker of bulimia. You will get a history of self-induced vomiting, where the patient will use the knuckle to induce vomiting, and that chronic usage will cause a callosity on the knuckles. This is the characteristic Russell sign, which is seen in the anorexia nervosa bullosa complex, bulimia complex. It is said that the former Queen Diana actually had these Russell sign on her knuckles. This is another entity I think all of you would have probably seen in your MBBS time itself. This is a central arteriole with a radiating thing. This is a spider nevi, which usually accompanies chronic liver disease. This is an entity I think pediatricians will be able to diagnose. Patient presents at birth with depigmented lanceolate macules. Then the patient might also have a shiny, leathery patch. We'll also have periungual fibromas. Then we'll have oily lesions on the face, which is called angiofibroma. Yes. So this is the first one is ash leaf macule, chagrins and all. So this is an entity called tuberous sclerosis. I think most of the pediatricians would have definitely seen, and the patient usually presents with multiple seizures, intellectual impairment, and multiple tumors of the CNS. But not only the CNS, you need to know that these patients can also have involvement of the heart, where they present with probably cardiac rhabdomyomas, and the kidneys, where they will present with your angiomyolipomas. This condition, if you see, then this urgently asks you to start a particular treatment in that particular entity. I think somebody has made a diagnosis. Yeah, so you have to start dialysis in this case. And this is the classical uremic frost, where the sweat, which is teeming with the urea, it will crystallize there and deposit in the hair follicles and the hair. And this would actually suggest that your blood urea nitrogen has exceeded that critical limit, and the patient has to be immediately started on dialysis. This is a uremic frost seen in chronic kidney disease. This is another entity. Before this condition manifests with its telltale signs, the patient or the mother usually brings the child with this particular lesion on the thighs or on the hairy areas, where the hair will be thrown into coils. And if you look very careful, there will be small perifollicular hemorrhages. This is the classical corkscrew hair. And can anyone tell what this could be an accompaniment of? Seen in a particular vitamin deficiency, where the patient later on presents with, I think that will be a giveaway clue, presents with bleeding of the gums and all. So it's a marker of scurvy or vitamin C deficiency. Now, this is, I think all of you know, this is the hyperkeratotic papules, the very spiny papules which you see on the elbows. You can see similar lesions on the knees also. And so this is the phrinoderma, which is usually seen. Can anyone tell what is the current concept regarding phrinoderma? It is deficiency of. So vitamin A was what is the what you call age-old explanation, but anything else? Now I think they say multiple vitamins, but more than that, it is the essential fatty acid deficiency, which is supposed to be the primary reason for phrinoderma. So this is another entity where there is a vascular malformation, and when it occurs extensively, you can have these sort of capillary angiomas and different vascular formation. If it occurs on the face, then this is the classical port wine stain, which accompanies which particular entity? The Sturge-Weber syndrome. And which is the system which is commonly affected with Sturge-Weber? The CNS. And the eyes also is one area where you get glaucoma and other changes. You can also get bone changes, because when you have these vascular malformation on the extremities, when you try to compare between two extremities, you will probably find a hypertrophy of the limb where you have this large vascular lesion. Now, this is a straightforward one. This is a xanthalasma, and it's okay. So the question here in xanthalasma is, how common is it associated with underlying lipid abnormality? Can anyone tell? Since I've asked, I think you will tell in percentages. Otherwise, you would have thought this is a telltale sign of hyperlipidemia. No, at the most 30 to 40%. Previous literature used to say 50. Now say only 30 to 40% of cases only are associated with lipid abnormality. So the chances are that more than often you are going to see patients with normal lipid profile when you evaluate, when you see this particular entity. So I think we are reaching the end. This is the Y. So if it is Y, then this should be the color yellow nail. And this is an accompaniment of HIV. But at the same time, there is an entity called yellow nail syndrome, where you can have lymphedema, you can have underlying respiratory disease, especially bronchiectasis, and then these nails. So this is a triad of yellow nail syndrome. And other entity where you get is when you see this yellow nails or extensive yellow nails, you have to do a what you call immunosuppressive profile check. This is the final one, the Z. So you have a patient who presents to you with multiple vesicles and which are crusty, and you can see the characteristic. If I tell that particular pattern, then you will be telling that it is a classical dermatomal pattern which you are seeing. So this is the herpes zoster. But then herpes zoster is something which is just an infective condition. It can be just a sign of immunosuppression. But what is classically a marker of immunosuppression is a disseminated herpes zoster or a multi-dermatomal herpes zoster where non-contiguous dermatomes are affected. It cannot be like C3, 4, 5. It can be where you skip dermatomes and the patient starts to get affected, or it crosses the midline. So if you have a zoster which crosses the midline and you have multiple dermatomes involved with sparing in between, then that is your multi-dermatomal herpes zoster. So I think I've bored you enough. This is a quiz for you. So I think you have multiple lesions here. I just tell you what this is. The first one is that this particular person will present to you with oral erosions. And I would request our dermatologists to probably keep the diagnosis to their mind. The rest can probably tell. So this is an oral erosions which occur. Same patient, if it's a male, will present with scrotal ulcers. If it's a female, it will be they will present with genital ulcer, usually vulvar ulcer. It's called ulcus vulvae acutum. It's an acute vulvar ulcer. Same patient will have erythema nodosum like lesion. Same patient will have acneiform eruption. Same person will have a folliculitis like lesion. And the patient will have eye involvement too. So this particular entity, I purposefully brought this because it's not that it is too common, but you get the after of the eyes and genitalia. But I purposely brought this because not everything in dermatology has been contributed by dermatologists. This one was contributed by a very famous Turkish ophthalmologist. So this is the Behçet's disease, and the person who was the Hulusi Behçet, who was the Turkish ophthalmologist. So there is a major after the scrotal ulcer, the eyes changes, and it's a Behçet's disease. But then Behçet's disease is not just an oro-oculogenital syndrome. The seriousness of this is that it can have very florid eye manifestation. More than that, it can have a constellation of neurological complaints, and you have an entity itself which is called as neurobehçet's. And one of the classical lesions which is seen is berry aneurysms and aneurysmal rupture, which is there as part of the disease. So once you see a diagnosis, once you see a after of the oral cavity and genitalia, we call it as a formiferous state of Behçet. Then you need to be extremely careful, and you should always evaluate the patient, and you should keep the patient under follow-up. So this is one. As I said, it can involve both the joints, it can involve the eyes and the CNS. This is another entity. I think it's easy to diagnose. The first one is the patient has got brownish tan macules. This is the classical cafe au lait macules, which is and such patients will have these sort of skin tumors. This is the cutaneous neurofibromas, which are otherwise called molluscum. And once you see this, we usually send the patient to ophthalmology, where they will pick up the iris hematomas, which are otherwise called the leash nodules. And the diagnosis is neurofibromatosis, and it can have involvement of most systems. In the if it presents with multiple tumors of the CNS and other systems, and in the bone, it can affect the spine, it can affect the long bones, and it can even affect the it can cause sphenoidal ring dysplasia, and similar changes can occur in neurofibromatosis. In type 1. In type 2, you don't get lesions, you usually get in type 1. So I think that brings me to the end of this particular session. What I've tried to do is that I've just tried to give you a a sneak peek into this particular topic, a bird's eye view into what, just to highlight that skin and systems are connected. This is by no means a comprehensive, complete coverage of skin lesions and systemic illness, just to impress upon you the connect between the skin and system. So not when you look at dermatology, so not everything is just at the level of skin. It might be showing something which is underneath. Excuse me. So I just thought I would put this particular cartoon. This, I think all of you know, it's the Vodafone cartoon Zuzu. But what is important is the one thing which is holding. This is something which is common between this particular cartoon, and this is one of our very important weapon for a dermatologist and for a detective like Sherlock Holmes. This is the magnifying lens. Now, this is what you use so that you magnify the skin lesion to see the different characters of skin lesion and try to make a sense out of it. Now, if you have an idea of what a particular skin change is suggesting to you in terms of systemic ailment, then only there is a chance of you making a correlation between the two and evaluating the same. So my purpose was basically to highlight that this can be an accompaniment of systemic illness, and I would be extremely happy if this talk would stimulate you to read a little bit, look into a little more images on skin and system, and you have taken some carry home points. And I will leave you with this particular statement, which is very commonly used in most of the academic forum, that the eye does not see what the mind does not know. So I just hope I have probably revised and rekindled some of the knowledge which you had, which we had kept in the back. and you have been able to probably bring that to your recollection. Thank you for your kind attention.
Thank you, Dr. Bifi, for the excellent and informative talk on systemic looking model of systemic diseases. Now, the topic is open for discussion.
So it was an excellent presentation. One of my friends is doing research on the aging of skin and how it reflects to the aging of internal. Do you have any comments regarding that? Because they are telling that skin is the largest organ in the body. So the aging of skin directly reflects liver, heart, and all other end organs. Do you have any comment on?
To have an expert with, I think aging skin can be both constantly as well as it can be simply of aging and packaging aging. There are literature which says that it can I don't have an exact
Aging, not in the very old people, but know that they are having the changes and section of the body and all of the things can be identified with DNA and RNA, etc. So whether it would be corresponds to the liver or heart or some other organ.
I don't have
Importance diet is particular.
But if the organ can be, you can have every day. You can have the large number. So this is actually the changes in there. And by the time it's percent, you get it many of the time. So when you look at it, you might not be able to pick out the organ. It is actually popular when you look at it in the tissue. Because of the extra. It's not it's not like the Pariyaram is on the legs. It's not it's. And just to add to what Dr. Speaker said, for a long time we have found that skin is the largest organ. Now it has changed. Now they think it's meter which is the largest organ. That was the decade now. But we still remember skin as the largest organ. For what I think we are not seeing anything. Interstation is how will you listen the art is there because radiology after radiology one specialty was skill because just seeing and like this they will give you very correct guidance. No, I think you are very lucky because it's not always the routine. You need to look at the patterns which can sometimes be picked up by artificial. Very important investigation research for going. Then what I understood is that aspect is many of the like images. It is images. Where most probably it will affect your specialty. But I think nothing is going to probably take away the benefit of history taking analysis. That an artificial analysis is not going to form. These are my way it's true. But the treatment part of the mechanism, the treatment part of diagnosis, you can add because somebody can add as So it is be very careful. Certain yes. You are because we know that this artificial is going to be real. So we have to so it's no point in telling that this is not going to happen. This is going to be a part of this. So we as I said, like we have to probably find this surveillance yeah, probably we can use
Same information with the native vertical see that when you evaluate you how to be non-negligent.
see vertical is already are reported reasonable as well as modifications. So there are instances of having the property setting is legal shapes in negligent. So that is something which is
So the board space now needs to comfort the. I don't know that one from that. We must have a team. Instead of a completely accommodated. More and more accommodated with more and more information. We don't see. For a combined. So you are. The government knows the need for more than combined. The ability to return that.
People is mandatory. You can't manage. I think we all. I think the basic of the also the people is not taking is team. You can't survey on it. I can't. We have doctors and we have proper regularly and we do it regularly. The next thing that medical diagnosis or the perfect diagnosis the candidate develop hospitals and models. We don't keep them to hospitals and manage diagnosis. Immediately suspect just rubber to actually and we do have a paper and multi-disciplinary approach. We don't keep these patients for that is one of the reasons why it is not a particular because just to highlight that dermatology, these signs are just a point of the system and not dermatology skin only. They're not stuck to the system and not to feel that. So it's not just for us, it's just for the discerning clinician to pick up the skin lesions and then how to we will.
No more question. Presentation memento. I invite Dr. Swami to present the memento to this speaker. ബ്രസീൽ ക്രൊയേഷ്യ എടുത്തിട്ട് ക്രൊയേഷ്യ ചെയ്തിരുന്നു. അർജന്റീനയും നെതർലാൻഡും ചെയ്തിരുന്നു. അപ്പൊ ഇതിൽ 4 പേര് കറക്റ്റായി എടുത്തിട്ടുണ്ട്. ഡോക്ടർ വിദ്യാധനഞ്ജൻ, ഡോക്ടർ നിതിൻലാൽ, ഡോക്ടർ അഭിനാഷ്, ഡോക്ടർ സുൽഗീത്. ഇതിന്റെ പ്രോജക്റ്റ് ഡോക്ടർ നിതിൻലാൽ. രണ്ടാമത്തെ പ്രോട്ടോകോളിൽ മൊറോക്കോ വിജയിച്ചു. ഫ്രാൻസും ഇംഗ്ലണ്ടും ഫ്രാൻസ് വിജയിച്ചു. ഇത് കറക്റ്റായിട്ട് എത്തിയത് ഡോക്ടർ അബൂബക്കർ, ഡോക്ടർ ഹാസി, ഡോക്ടർ ദുൽഫിഖർ, ഡോക്ടർ വിമൽ, ഡോക്ടർ ഹരിനാഥ് സാഗർ, ഡോക്ടർ വിമൽ നന്ദിയാണ്. നോട്ട്സ് എടുക്കാൻ വേണ്ടി second Dr. Kannur. First semi-final. Argentina, Croatia വിളിച്ചിട്ട് അർജന്റീന വിജയിച്ചു. അതിൽ more than 40 members കറക്റ്റായി ചെയ്തിട്ടുണ്ട്. അതുകൊണ്ട് ആൾക്കാർ പേര് വിളിച്ചിട്ടില്ല. നോട്ട്സ് എടുക്കാൻ next is second semi-final. France, Morocco versus France വിജയിച്ചു. Last round. Second semi-final. France vs Morocco. France വിജയിച്ചു. ഏകദേശം 40-ലധികം ആൾക്കാർ കടക്കപ്പെട്ടിട്ടുണ്ട്. Dr. CBC. Next is photo class.
We Kannur express our sincere thanks to Dr. Bifi Joy for accepting our invitation from the CIA and for this excellent